So welcome everybody tonight to the session. Tonight our session is going to be talking about air leaks, and we have Dr. Mizing Kerala who's going to be doing the talk. He is the Associate Professor at the University of North Dakota and the Medical Director of Critical Care Services at Sanford Health System. So thank you, Dr. Kerala, for joining tonight, and we look forward to what you have to say. It's good to see familiar names back again this week and some new faces too coming to join. Just going to mention briefly about some of the upcoming events. There's an event tomorrow night, and that's at 8 p.m. And the event is going to be talking about right-sided heart failure, and that's with Dr. Halal Dahan. There's going to be no ventilator session next week. However, the week after, which is the 10th of August, there is going to be a meeting which is on double triggering on mechanical ventilation. So without further ado, if I can just pass over to Dr. Kerala to begin the chat tonight. Thank you.
Oh, thank you very much, Grace. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much for joining our ventilator round. I just want to make sure that you understand those ventilator rounds, how they are conducted. We're doing this almost on a weekly basis, but some weeks I'm not available. So I may skip that week, and next week there will not be a ventilator round. The week after, we're going to be talking about double triggering, as Grace mentioned. At the same time, those rounds should be limited to 20 to 30 minutes, and then we leave 15 to 30 minutes, if you want, for discussions. And today we're going to be talking about air leak, how we detect it on the ventilator, and what can we do to improve it. And let me see if I can advance the slides. So as you probably all aware, that the causes of air leak would be either leaking air in the circuit, in the ventilator circuit, or the endotracheal tube cuff. That could be caused by either loose connection in the circuit, deflated balloon, or it could be actually if you put the NG tube and by mistake it was malpositioned in the trachea, it will actually cause some leak. At the same time, if your patient is intubated for a longer time, or he has tracheomalacia to start with, the balloon that you have in the trachea tube or the tracheostomy may not be able to seal off everything, and then you end up with air leak. So those are usually easily corrected compared to if the patient is leaking from the pleural space or leaking into the pleural space by either bronchopleural fistula or alveolar pleural fistula. And those are difficult to differentiate. However, they manifest the same, and the treatment is the same. Whether the patient is actually leaking into the pleural space directly from the bronchi or bronchioli, or the patient is actually leaking from the alveoli. This could be because of pneumonectomy, lobectomy, post-surgical or post-operative, which is the most common cause. It could be trauma to the chest, of course, VILI or ventilator-induced lung injury in patients with ARDS, or patients with necrotizing pneumonias, tumors, of course, emphysematous lungs, and you can name other conditions too. So the air leak would manifest with two main things on the ventilator, and the physiologic mechanism would be that the compliance is increased. Of course, if you're leaking air, it would be so easy to put that air in the system, but it's leaking out. So there's no resistance to the air, and that's why the compliance is increased. It would manifest mainly by loss of the volume that you put in. You put in 500, however, you leak 200 or 100. At the same time, since you have the increased compliance, you're going to lose the pressure. You may lose the inspiratory pressure or the expiratory pressure, depending on, or you can see it based on how you're going to pay attention to inspiration or expiration. So we'll see that together actually. And I'm going to identify first how you detect it by looking at the scalars. And the patient, as you see here, is on volume control mode of ventilation. You can see how the pressure is increasing in inspiration, so it's not pressure control, even though the flow waveform is decelerating. So of course you can do volume control with decelerating flow wave. And you can see the tidal volume 400 as a result of 15 centimeter here of inspiratory pressure, and the flow goes up to 40 liters and then decelerates. In expiration, you can see the expiratory flow. This is the peak expiratory flow, and then decelerates gradually to go back to the zero level. And this is a breath without leak. The next breath here, let's just follow along what are the changes. The first thing that you see is the initial rise in the pressure is the same. And this initial rise in the pressure represents the pressure required to overcome. Okay, so the initial rise in the pressure is the pressure required to overcome the airway resistance. And since there's no problem with the airways, it's the same thing actually. The pressure is usually the same. And then the pressure goes up to the peak inspiratory pressure. And you can notice that there is a decrease in the peak inspiratory pressure. And that's why, that's because you're losing air in the system. And this is actually for bronchopleural fistula. There is no problem with the airways here because you're losing air into the chest cavity. And if you have a chest tube, it comes out, of course. If you don't have chest tube yet, this is a different story. So I'm talking about air leak that is already managed. So the peak inspiratory pressure is going to be decreased because the compliance is increased. And then you can measure the inspiratory volume and the expiratory volume. The area under the curve in the flow over time scalar would represent the inspiratory volume here. And you can see this area is bigger than the expiratory volume. So the area under the curve in expiration is smaller than the area under the curve in inspiration. So that means we put, for example, here 400 ml in, however, we exhaled only 300. Why this happened? Because we lost 100 on the way in. And the machine doesn't know that yet. So we'll see how the machine is going to read that. So here what you see is inspiratory volume is larger than expiratory volume. At the same time, you can see that the peak expiratory flow is decreased because we don't have that much volume actually compared to the previous one. You can see here the peak expiratory flow compared to the one that has air leak, it is decreased. And not only that, you can finish exhalation faster. We have less volume that needs to be exhaled, so we can exhale it faster. And you can see all this on the flow over time curve or scalar. And then we look at the volume over time. So this is the inspiratory volume, and the machine measures what it delivered. And you can reach here 400 ml. This is similar to the previous one here. The machine doesn't know that we leaked 100 yet. So the machine in expiration will measure the volume. And you can see the volume goes down gradually. It would have reached 0 if we did not leak some of this air. However, since we leaked 100 here, so the volume goes down to 100, and then there's no more volume in the chest. We lost 100, and the machine would wait. It's like, this is measuring nothing because there is no flow. You can see here, the flow is 0. So that means we finished exhaling everything that was in the chest. And the difference between this line and the 0 line would be the leaked air, or the leak volume. So the volume does not return all the way to 0, and then before the next breath, the machine would realize that the patient did not exhale everything that was put in. However, the machine needs to recalibrate. So what you see here, this is a wedge that goes down to 0 because the machine recalibrated to 0 line before the next breath. So you see this edge like this. So again, to summarize the manifestations of air leak on the ventilator, first, you have a decreased peak inspiratory pressure. Number 2, the inspiratory volume is higher than the expiratory volume. Number 3, the peak expiratory flow is lower, and the expiration is faster than the previous one. Then on the volume over time, you see that you do not return to the 0 line because you lost that part of the air that was leaked. And then before the next breath, the machine will recalibrate, and the difference between this line and the 0 line would be the leak volume. Now, one other thing that you may see when you have a patient, if you notice the first one, I put a PEEP of 0. Now, what if I have a PEEP in the system? And just to make it easy, in ARDS patients, we do inline suctioning. Why? Because we say we don't want to open the circuit and lose the PEEP. Well, this is what happens. You would lose the PEEP in a patient with air leak. If you have a PEEP in the system, and this is a PEEP of, I see here, 10, okay? And this is a breath without air leak. This is, and you can see here, the volume returning to 0. You can see the inspiratory volume is similar to the expiratory volume. Compared to this one here, it's initiated by the patient, yes, and the line here that we have is the trigger line. This is what, how much pressure the patient needs to develop in order to trigger the ventilator, how much negative pressure the patient needs to develop. And this is triggered by the patient. This is a pressure control breath, but the patient has PEEP in expiration. So you see here, when we go back to the PEEP level, because of the leak, we're losing that PEEP. Okay? And that results into a drop in the inspiratory pressure in the circuit. And if we see that inspiratory pressure reaching the trigger level, we lost the expiratory pressure, which is a PEEP. I said inspiratory, no, it's expiratory. We lose the PEEP, and that expiratory pressure would actually get to the level that would trigger another breath and would cause what we call auto triggering. So this is the air leak. This is similar to what we just talked about in the previous slide. However, because of the drop in the PEEP into the trigger level, that triggered the ventilator for another breath. And this is what we call auto trigger. So this breath is triggered by the drop in the expiratory pressure. It's not triggered because of patient's inspiratory effort. In order to trigger by the patient, you need to drop that expiratory pressure to the trigger level. However, because of the leak here, that pressure drops to the trigger level and triggers the ventilator. And then we need to see this on the flow volume loop and the pressure volume loop. So let's start with the flow volume loop. And this is before the leak. You can see the flow goes up to the peak inspiratory flow and is maintained here, and then decreases to start expiration to the peak expiratory flow before going back to zero. So by increasing the flow to the peak inspiratory flow, the volume would go up to the tidal volume. So this is the tidal volume here. If you have a leak, the inspiration would be the same. You can see the flow, similar to the breath before the leak happened. In expiration, we said the peak expiratory flow would be lower. And you can see here how the peak expiratory flow is lower than the previous breath. And then we are exhaling. However, since we lost air here, the line would not go to the zero line. And the difference between the intersect with the flow and the volume here would be the volume of leak. So you can measure it on the volume flow loop. On the pressure, at the same time, we talked about the decreased peak expiratory flow here. So on the pressure volume loop, notice here there's no peep. So I go from zero expiratory pressure to the inspiratory pressure, and that results into the tidal volume. And then in expiration, the pressure goes down from the inspiratory pressure all the way to zero. If we have a leak in the system, what happens is, as I mentioned before, look at the pressure won't go up to the same level as the previous breath. So there is a decrease in the peak inspiratory pressure. At the same time, the pressure would not go back to, the pressure would go back to zero, but the volume would not go back to zero. It would actually cut off at the level where the leak volume is. So if you lost 100, we would go down to the 100 level. And if it is 200, it would actually cut off here. So it is actually very easy to see how the volume of leak is actually represented or detected on the flow volume loop or on the volume pressure loop. So let's go through some cases. This is a 47-year-old patient with pneumonia and ARDS. Ventilator pressure fires, and further investigation reveals elevation of both the peak and plateau pressure. Physical examination, decreased breath sounds on the right, and there was an ultrasound examination that shows lack of lung sliding, and there is no lung pulse or vertical artifact present. X-ray confirms right-sided pneumothorax. They put a chest tube and they put it under suction. However, a large continuous air leak is still present, and the patient remains hypoxemic. So let's take a look on here. Well, this patient is already leaking, so we cannot compare the pressure with the previous pressure before this started. You can see here the peak pressure is 21. Now take a look on the volume, and you see the pink indicates that those are all started by the patient. So the flow over time, the area under the curve is the volume. And you can see how much he's leaking actually. Look at the area under the curve here compared to the area under the curve in expiration. And you can see, well, we're inhaling that much volume, and exhalation is very little. Now take a look here. You can see the inspiratory tidal volume. We're putting 450 in, and we're getting out only around 100. So this patient is leaking 350. What does that mean? Well, we're not ventilating the patient at all, because that 100 is going to be utilized for the dead space. Very minimal volume left for the patient actually to ventilate and oxygenate. That's why he continued to be hypoxemic and hypercapnic. Now take a look on the volume. You can see this is the inspiratory volume. However, most of it leaked. So in expiration, you will see the volume goes down to this level and maintains this level before the next breath. And this is the wedge that I told you about. This is a recalibration because we lost the volume. We cannot exhale anymore. But before the next breath, the machine needs to recalibrate. If you do not recalibrate, it's going to be just escalating. So this is very clear that this is a very large, huge air leak that needs to be addressed right away. The second case is a patient who was diagnosed with possible ascending flaccid paralysis, Guillain-Barré, received 3 cycles of plasmapheresis. Subsequently, the patient developed breathing difficulty and required mechanical ventilation. He was transferred to the ICU. They put a feeding tube for him, and he was connected to the ventilator. And this is what you see on the ventilator. Now you see the loops here, and you see the scalars here. So if you go with the scalars, this is pressure control mode of ventilation, and the peak pressure is 19. This patient has a pressure PEEP of 5. Okay, and in the flow over time scalar, you can probably detect that the inspiratory volume is not the same as the expiratory volume, but you don't have to worry much about this if you cannot see it, because you see it here. Look at this volume. This is inspiratory volume. In expiration, it doesn't come out all the way. That's why we have a wedge here. And you can see the inspiratory volume 382 and expiratory volume 284. So at least is better than the previous case. We're losing 100 here every breath. If you take a look on the flow volume loop, you can nicely see that this patient is on decelerating flow waveform. And then this is the start of expiration. So this point correlates to this point here. You can see the peak inspiratory flow here. That is the peak of the inspiratory flow here. And then since this is decelerating, this decelerates gradually. Okay, so this is the inspiratory volume from this point here to this point, which is 382. Now in expiration, you can see that it goes down to the peak expiratory flow, and this is the point that correlates with this point here. Notice the rapid decrease in the flow, and that's why you see rapid decrease in the flow here. And then it decelerates gradually to the level of 0, and that's what happens here. We decelerates in the flow to the level of 0 in the flow. However, when we get to a flow of 0, we don't get to a volume of 0. We get to a volume of 100, or exactly 98. And that would represent the difference between this point and this point would represent the volume of leak. And this is exactly similar to this area here. On the volume pressure, it would be this part here. So this pressure goes up to the peak inspiratory pressure. Notice that it is maintained at the same level because it's pressure control mode of ventilation. So you can say that you can see that the pressure is maintained, and that's why it is maintained here. While the pressure is maintained, the volume goes up. and the volume is increased here, that represented on the volume pressure loop on the y-axis. And then you can see how rapidly the pressure goes down to the PEEP level, and that's what happens here. The pressure goes down to the PEEP level, and you exhale. That dent that you see here is correlating with this one here and this one here. So that is the loss of the volume. However, the volume doesn't go back to the zero level in the volume. It goes down to the PEEP level. This is the PEEP level. However, it stops here and recalibrates. Of course, you need to complete the loop. This part here is the volume that is leaked. And actually, in this case, you can see, I'm not sure if you can see it actually clearly, but this is the endotracheal tube. And you can see that there is an NG tube or feeding tube that is placed in the trachea. And it created that gap between the balloon and the tracheal wall that allowed for this 100 of air to be leaked. And this is after let me just see if no, this is a different patient also. It represents the same thing. However, this patient is on volume control mode of ventilation. And you can see the same thing. The volume in the inspiratory volume is larger than the expiratory volume. And that's why you have the whip here. Now, the second case, this is a case that just I had a few days ago. And this is a patient who had endotracheal lesions secondary to lung cancer, status post debulking procedure. And this is the second debulking procedure that he had. You can see before the procedure started, you can see all this mucus or mucus plug that is actually plugging the bronchus. This is suctioned out, and this is what we saw. And then we advanced more and suctioned more, and then we saw a gap here. This dark hole, what you see, this is a bronchopleural fistula. So the patient was actually having major air leak, and he's leaking into the pleural space. And this is actually to show you, you're not only going to lose the PEEP, but also you lose the inspiratory pressure. So what I did here, I held the inspiratory pressure in inspiration. And you can see this is inspiratory pressure, this is expiratory pressure. And then the next inspiratory pressure, I held the inspiration. And what that caused is a decrease in the inspiratory pressure because you keep losing that air into the pleural space, and the pressure is actually decreased gradually. And the same thing, the amount that he was leaking was probably around 150 every time. Now, the last two things that I want to mention to you is the difference between air leak and auto PEEP. If you're only looking at the volume over time curve, you won't see any difference. Again, think about it. In the air leak, we put 500, we got out 400, we lost 100 outside the lungs. In the auto PEEP, we put 500 in, we got 400 out, we kept 100 inside the lungs. So the volume over time would be the same. We put 500, we got 400 out. Before the next breath, recalibrate. We put 500 here, we got 400 out. The remaining 100 is the air trapped. Okay. So that's number one. Now, if you take a look on the pressure, if you don't have PEEP, you don't see any difference. If you have PEEP in the air leak, you may see that you're losing that PEEP. But if you put an expiratory hold, you will see that the PEEP is lost in the air leak if you have PEEP to start with. In the auto beep, what you see is you measure that auto beep. So the pressure would go up. If you put expiratory hold, here you lose the pressure. Here you measure the pressure. You measure the actual auto beep or alveolar pressure. And if you take a look on the flow over time, it is clearly that this patient did not finish his exhalation. So you see persistent flow at end of expiration. Here you see that the patient exhaled all the way down. Now the other thing is there a difference between would you rather do volume control or pressure control in a patient who has air leak? Well, just to give it from the end, volume control is easier to manage. Patients can be easier managed on volume control. However, you need to understand they both have problems. If you put volume control mode of ventilation and you want the patient to get 500, he's losing 100, so you're going to lose volume because the patient is not going to be able to get all the volume. Okay, the pressure would go down. Now, in pressure control mode of ventilation, since the compliance of the system is better, since we have air leak, well, that pressure is going to be fixed. And because the compliance is better and based on the equation of motion, you're going to put more volume in. And that more volume in, meaning that we're going to lose more volume. So you see here, we lost 100. If you put the same patient on pressure control, that pressure will actually result into larger air leak because of the improved compliance of the system. I think that's all what I have today, but how do you manage this? I can quickly speak about it. Of course, you need to minimize the pressures. You need to give time. Of course, if it is a balloon that needs to be inflated, if the endotracheal tube is malfunctioned, you change that and you solve the issue. But if the air leak is into the pleural space, this is more difficult to manage. So you need to minimize the inspiratory pressure and the PEEP pressure, so you don't cause more leak into the system. And you need to, in order to do that, you probably need to decrease the tidal volume. So minimize the tidal volume to minimize the pressure. If you're on volume control, you need to decrease the volume. If you're on pressure control, you need to decrease the pressure. And you need to minimize the PEEP. If the machine is auto-triggering with the loss of PEEP, at that time you need to decrease the PEEP to 0. And if you can manage with a PEEP of 0 in a patient who's leaking into the chest, it's better than if you keep the PEEP in the system. If you don't need the PEEP, remove it. You can also lower the inspiratory time. You don't want to put the air in. As I showed you, when I put inspiratory hold, you're going to lose that pressure. So you need to limit the inspiratory time and reduce the respiratory rate to lessen the mechanical power or energy applied to the injured lung and give it more time to heal. Of course, while you're doing this, you're going to accept permissive hypercapnia because of the reduction in minute ventilation. In severe cases, you may have to do independent lung ventilation, and that's what happened in the first case that I presented. And in other cases, you may have to do VV ECMO to bypass the lungs altogether. With this, I'm going to stop here, see if you have any questions. Grace?
There's no questions yet in the chat, so if anyone would like to ask a question, feel free to put it in the chat or feel free to unmute yourself and ask it directly.
I guess it's very clear, and did not expect that we're going to have many questions generated out of this, but It is really important for you to be able to detect air leak very quickly and know how to manage it. Most of the cases, you're going to have some loose connection in the circuit. The balloon is not inflated enough, and you're going to have more difficult cases. Those are easily managed. However, you're going to have more difficult cases where, especially if you have trichomalacia or if you have large bronchopleural fistula. But you as an intensivist should be able to detect air leak quickly by just looking at the scalars like what we talked about. You're not going to be able to see the decrease in the peak inspiratory pressure. However, by looking at the flow, you can see differentiate the difference. By looking at the volume, you can see the wedge.
Lovely. We have some questions here. So first question, can you explain the difference between volume and pressure mode in air leak?
You mean again, right?
I think it must be a recap question. This was just asked about.
Let me go back to it. Okay. So I'm not sure if you see the equation of motion at the bottom, right? Let me just, this is the one here. So you can see the equation of motion here. And this is actually very important that, you really need to understand the equation of motion. And that's why I started those ventilator rounds by talking extensively and deeply into the equation of motion. So the equation of motion is the difference in the pressure on the left side should equal resistance multiplied by flow plus volume divided by compliance. And if you have air leak in the system, what does it mean? It means that the compliance is improved. Okay, you have a hole, you can easily push air through it. Compliance is less. Okay, this is the opposite of decreased compliance in a patient where you have a pneumothorax, for example. You have leak, but you're not leaking outside the chest. So you put pressure on the chest. So I want you to differentiate between this. The manifestation of air leak with a pneumothorax that is not drained is completely different than what I'm talking about here, an air leak that is leaking outside the chest cavity. Okay, so I put it in red here, so you can see that the compliance is increased. If you are on volume control mode of ventilation, this volume is fixed. The machine is going to deliver 500. Since the compliance is improved, the pressure is going to be less. And that's what you see here. The pressure is decreased. On the other hand, if the patient is on pressure control mode of ventilation, the left side of the equation is fixed. You put the patient on pressure of 30, PEEP of 10, the difference between peak and PEEP is 20. That is fixed. If the compliance is improved, what you see larger tidal volume put in because the compliance is better now. So in this first, we put only 100, 300 ml. In the second one here, we put 380. So that means if you put more air in, percentage of that is going to leak out. So the leak amount on pressure control is going to be higher than the leak amount on volume control. Of course, what you need to do is you need to decrease the pressure. If you want to give this patient pressure control mode of ventilation, just decrease the pressure, but you need to maintain adequate ventilation and oxygenation. Thank you.
Lovely. Thank you for answering that question and for just giving us a recap. Another question that you've been asked is pressure control superior to volume control in air leak?
It depends. It's actually, there's no preference of one over the other. You need to understand the consequences of each mode with air leak. So if you understand that here you're losing volume, you need to lose to use larger volume in order to ventilate the patient. Okay. On the other hand, here is the pressure is determining how much volume you're going to get in. If that pressure is providing you with adequate volume despite the leak, let's just say that you cannot correct the leak. Okay, in both cases, doesn't matter. If you correct the leak, we're done. We solve the problem. The situations that are difficult are the situations where I cannot remove that leak. At that time, you need to look at ventilation and oxygenation, and you need to minimize the pressure. So whether you use pressure control or volume control, well, the aim is to utilize the minimum pressure possible and the minimum volume possible that will allow the lungs to heal and close that air leak while you're ventilating the patient.
Lovely, thank you. There's a few more questions if you have time to answer them. One of them is quite straightforward, and it's talking about can we watch the previously recorded lectures, and that is accessible on the website. There's also the ability, you can also record while you're
Grace,
watching.
I want to mention that it's, those are accessible on the website for people who are supporters for the website. And it's a nominal fee for supporting the ICU Reach. It's very minimal fee per year, and you get access to all the recorded lectures. And the reason why they're not available for free, because we will not have this interaction. Everybody is going to wait for the recorded session, and that's what we experienced in the past. I think the interaction is very important. We like to get your questions and answer them. And they are available under the event tab. Just click on past webinars. Go ahead.
Great, thank you. And also by becoming a supporter, you can access other educational materials, not just the lectures, but there are self-paced courses and other materials you can use too. So that's a good question. And we would be really grateful for your support as well. So moving on, another question. Would we prefer oxygenation to ventilation while losing PEEP, specifically in our ARDS with severe hypoxemia?
Well, this is the most difficult clinical scenario that we encounter. I think Salma asked this question, right, Dr. Salma? Well, the problem is that now you have two contradicting interventions that you're going to utilize. You're going to decrease the PEEP to improve air leak, and you're going to increase the PEEP to prevent atelectrotrauma and keep the lungs open in ARDS. Now, those are the difficult cases where you probably need to think about, first, in conventional mode of ventilation, it's really difficult. You need to find a balance where you're minimizing the air leak and keeping oxygenation. If you can find that balance, if you decrease the PEEP to 10 and the leak is not that much, you're able to compensate for it, excellent. However, if you're not able to compensate for the leak is huge, you need to go down on the PEEP to 0, and then that resulted into poor oxygenation, not able to oxygenate the patient. Well, you cannot manage this with conventional method. What you need to do then is, if you have a ability to do double intubation, would be great. I mentioned this actually in the last. What you do is you put a tube that has two lumen, one on the right side and the other one is on the left. And you do what we call independent lung ventilation. You provide the right lung if the leak is on the left, ARDS bilaterally, so at least you provide the right lung with adequate PEEP and the left lung with minimal PEEP. This way you can correct the problem. In fact, actually, the first case was managed this way. However, it might be difficult to do it, and the answer to this difficult problem would be ECMO, that you need to get the circulation outside the body, oxygenate outside and ventilate outside, and bring it back to the patient without going through the lungs, and give the lungs a minimum pressure to heal.
Lovely, thank you for answering that question. Next question is there any role for high flow oscillatory ventilation in management of patients with bronchopulmonary fistulas?
I think, the answer is no. In order to use high flow, well, I'm not sure if it is studied in this or not, but the high frequency ventilator, the principle of it is mean airway pressure, and that mean airway pressure is maintained at higher level. So it would cause air leak constantly during the oscillations on the ventilator. If you want to use it, that means that you're going to minimize the mean airway pressure to a very low level in order to minimize the leak. So think about the mean airway pressure in high frequency ventilation similar to the PEEP level, because that is maintained at all times. So I would say, I don't think it's been studied, but theoretically, I don't think it's, if you're dealing with a big leak, it's not going to benefit.
Lovely, thank you. This question might be more related to next in 2 weeks' time, the topic that you're talking about, but I'll ask anyway. In order to address auto-triggering in assisted breath, does it matter the trigger you set? Would you suggest flow or pressure triggering after setting the PEEP to 0 if tolerated by the patient?
Yeah, thank you very much. I think it's a very good question because, yeah, it answers. So the reason why it triggers, because you get to that, let me just go back to it. So if you set the pressure as a trigger level and the PEEP is decreased, you trigger the ventilator. However, if you set it based on the flow, you don't have the flow and you don't trigger the ventilator. So if you have a ventilator, they can choose between pressure or flow, you set it at the flow. So you don't trigger based on, and you can keep the PEEP. However, if you cannot control, if your ventilator is set based on pressure only, at that time you need to do ZEEP or zero PEEP. Okay. Most of the newer ventilators, like the Dragger, for example, it is only available to trigger based on the flow. You don't have this problem. But this is a very good question. It means that we're able to understand the concept of triggering and how the leak is going to affect the auto trigger.
Thank you. Another good question. If the air is leaking, how can we calculate the volume for ARDS?
Well, again, it's what you leak is subtracted from what's left. So let's just say if your tidal volume is calculated based on the predicted body weight as of 400 ml, for example, okay, and you put that 400 in, and you have 100 leaked, it's going to be very difficult because it's not going to be like you putting the 400 in and 100 directly goes into the leaked area. It may actually go into the lungs and then disseminates and it will leak out. And that's why I said important thing that you do with the management is to decrease the inspiratory time. You need to minimize the time where the volume is in. Now, does it mean that I would just adjust the tidal volume after subtracting the leaked volume? No. what I would do is I would try to see with protective lung strategy, you have 4 to 6. You can go up to 7 ml per kg, but I would try to see to stay within this limit. If I can keep the volume, total volume, including the leak volume, less than 7 ml per kg, would be preferred, because I cannot estimate exactly what is the effect of the TADA volume on the other alveoli before it leaked. And this has not been studied clearly, and it's very difficult to study it actually. So better off if you're able to ventilate with a TADA volume of 7 ml or less, that includes the volume that leaked, would be preferred in ARDS patients.
Lovely, thanks very much for answering that question. Which mode do you prefer for air leak?
As I said, it doesn't matter as long as you understand what are the consequences of that mode of ventilation. But I use volume control because I like to control the volume that I'm putting in.
Lovely. Well, that is the end of the questions. If anyone has any extra quickly to put in before the Zoom call ends. Otherwise, those questions have all been great, and thank you so much for answering them very clearly. Dr. Kerala.
Thank you, Grace. Thank you very much, everyone. We'll see you in 2 weeks from now. Tomorrow, we're going to have another session from Dr. Talal Dahan, and he's going to be actually wrapping up everything he discussed in the last 5 or 6 webinars about right heart failure in critically ill patients. So if you missed the previous ones, I think tomorrow is very important. And this subject is extremely important as we are expanding our understanding of the effect of the ventilator and ARDS on the right heart. So we're going to have it tomorrow at 8 p.m. Istanbul or Riyadh time. That would be 6 p.m. London time or Greenwich time. It's going to be at 1 p.m. Chicago time.
So globally, it's very different for everyone. But like Dr. Carla said, it would be great to see everyone there. And just mentioning again, if you haven't already, go onto the website and check out some of the options for becoming either bronze or silver member, and just the things that are included with that, and the extra presentations, the educational materials. And I think everyone would really benefit from that. And there's also blogs on the website and different things that you can read and learn more about. So thank you everyone for joining tonight.
Thank you.